Good afternoon, colleagues, and welcome to this week's deep dive after a little bit of a break. Lovely to have all of you with us. I see we've got about 40 people in the room and people are still entering. So while that happens, just a quick reminder for everyone to put your name, surname, and your MP number in the chat for CPD purposes. And if you've not done this before, also please add your email address so that we've got a place to send the CPD certificates to. Now, just to let you know, that will happen at the end of the year. We are currently working on last year's CPD certificates. My secretary has confirmed that she's busy with that. And all of these that we're collecting now will go into a spreadsheet, and then by the end of the year, these will be sent out. If for some reason, let's say you get an audit or some other problem, you really need to get it earlier, discuss it with us, and we'll see what we can do. So that's just by way of opening. And then also, if anybody is here for the very first time, a big welcome. To just give you an idea of how this meeting works, this meeting was started with the key focus on our trainees and to see whether we can give them a contextualized approach to hematological conditions and their diagnosis and management within a South African, sub-Saharan African context. So that's what makes this a little bit different from just reading the textbooks and the general literature, is that we try to give a local flavor within the resource availabilities that we have, and also to share some of the unique ways in which we have been able to deal with certain challenges. You will see that Irma Poulet, who has been organizing these meetings, thank you, Irma, has sent out in her invitation email a request for topics. And I can also, maybe if you have specific topics that you would like to be discussed here, you can either email Irma, or you are also welcome to put that into the chat box. We record the chat box, and I'm sure Irma will be watching that as well. But generally speaking, what we try to do is sort of look at the last 2 years' ASH education books and make sure that we cover all of those topics, or as many of those topics as possible. So with that, we are very excited today to talk about a topic that we do not talk about every day, and I think that has got some interesting flavors from an African perspective, and that is hairy cell leukemia. And to introduce our speakers and to chair the meeting, I'm going to hand over to Dr. Charlene Parasnath from UKZN, because our team today is from there. So thank you very much, Charlene, and I hope everyone enjoys the meeting very much.
Good afternoon, everyone. Thank you, Vernon. I think Marie is one of our speakers. She says she's struggling to join in, but let me just introduce our speakers today. So we are very privileged to be in the company of two very special people to me, both clinical hematologists and who have added tremendous value to our lives in our unit, despite not being part of our unit. And the first one being Dr. Rita Govender, who I first met when I started off as an intern in 2000, and she was finishing off her time in hempath, clinical hematology, and she's been a mentor ever since, and I was unfortunate that she had left when I'd started doing clinical hematopathology. However, over the years, Rita has continued to help us, and she's committed to academics and teaching and sharing. So Rita is based at Ampath in Durban, and although she's her work is predominantly pathology based, Rita does have a very, very keen interest in clinical hematology. And so she's previously also worked in Sandbus in Durban. And so without further ado, I'd like to hand over to Rita, who will be, her topic is, sorry, she just sent me her topic now. She has the pathobiology of hairy cell and how nothing in life is random. So over to you, Rita.
Good
Hi,
afternoon.
sorry to interrupt. Rita, were you able to upload my talk?
No, I
Okay,
wasn't.
Sorry, I had to email you my talk because I'm having a problem. Are you able to hear me?
yes, we can hear you, Marie.
I can hear you, Maurice.
Oh, okay, maybe I should start because mine is the case presentation.
Okay, so Marie's, okay, so we'll start with Marie's then. Okay, so Marie's also very, very important person in our lives. So she's a woman of many talents, and the important thing about Marie's is that she's actually allowed our services to grow in KZN, in the Department of Health. She's currently the HCU of Gray's Hematology, and unfortunately she's the only staff member there. So she's pretty much running the show on her own, and she offers tremendous support and outreach to what we call Area 2 in KZN. And yeah, so our aim when Marie's came across from Gray's to train as a clinical hematologist, she actually came in to our unit in a Gray's post. Marie's is a physician by background, and the whole aim there was to train Marie's and allow for that area to develop. Unfortunately, we do not have the resources at the moment in the province to support Marie's with human resources, but hopefully in time that service will grow. And because bearing in mind that KZN has a population of close to 12 million people, and we only have one medical university, and the services predominantly are based in Durban with the two major hospitals, King Edward and Albert Lutuli. And the whole aim is to actually have Gray's develop and help to provide a service there. So without talking too much, I would, Marisa's topic is, I think, a hairy situation. Marise, over to you.
Maurice, can I just check that you are not muted?
Can you hear me?
There, we can hear you now, but there seems to be an echo. So can I just ask anybody else that is not muted to mute themselves? Thanks.
Okay, can you hear me?
Do you by any chance have both your cell phone and your computer going? Because I see everybody is muted, but there's a very strong echo that usually means a cell phone and a computer is connected to Zoom. Is that possible?
It looked like there was two bizarre. I saw two on in the list. So I think she does have two devices running.
Yes.
I do have two devices. Or else, Rita, can you perhaps load your? Are you able to load your talk and I can?
It's working now. The echo's gone, Maurice, and we can see your screen.
Okay, can I talk now?
Yes, thank you.
Okay. My first case is, let me just move this. a 46-year-old female who was retroviral disease negative, and she presented to Greytown Hospital, which is a district hospital here in KZN, with a 3-month history of abdominal swelling with associated fatigue and malaise. She had no dyspnea, cough, or constitutional symptoms, and at the base she had received 2 units of red cell concentrate, and she had been on iron and folate supplements since January. And she was referred to Grays in April of 2019. And at this stage, she'd had 6 months history of symptoms. Sorry. On examination, she was a very slender woman. And you could actually tell that she had a mass, and she had a massive splenomegaly, which was 9 centimeters below the costal margin. And there was no lymphadenopathy. And the findings were supported on imaging done later. On her full blood count, you can see she's got a pancytopenia with a severe neutropenia. And of note, the monocytes actually appear increased. However, that peripheral blood was reviewed and the differential count was reviewed. And you can see that she had 0 monocytes, right? And what they did find were 14% of small mature lymphocytes with mature nuclear material and fine cytoplasmic projections. But interestingly enough, at her base hospital 2 months prior, a technologist had this to say. Notice under white cell morphology, there's no note of lymphocytes. However, in the blood smear comment, there's features suggestive of bacterial infection, etc. But the diagnosis of hairy cell leukemia was given, which I actually thought was, it was quite special. I only found this when I was preparing to present this talk. On her bone marrow, well, it was a very difficult bone marrow. I did not get an aspirate, okay, which was quite typical. On the trephine, you can see it's a CD20 or a B cell infiltrate. And the CD11C was positive in the majority of the neoplastic cells, right? Then flow cytometry was done, and on flow cytometry, the hairy cell markers of CD103, 123, 25, 11C, and Le were identified. And the BRAF mutation was subsequently done, and that mutation was positive. My second case is a 79-year-old Mr. RS, and he presented with fatigue and dyspnea. The GP had looked at the full blood count, and he was told that he had thrombocytopenia. He actually lived in Ladysmith, then traveled to his daughter in Durban, where they saw a private hematologist, and was then referred to Grays, which was his base hospital, at least nearest referral hospital, and he needed a bone marrow. He'd been previously well and had no comorbidities. On examination, he had a 2-centimeter splenomegaly. This was his FBC. You can see he's got pancytopenia, but very mild anemia, a white cell count of 3.67, and a neutropenia. And of note, his monocytes were also noted to be high. However, when the manual diff was done, the monocytes were actually quite reduced, and there was a population of 31% atypical cells with hairy cytoplasmic projections. A bone marrow was done, and this was actually quite an easily obtained aspirate, but there was 24% atypical cells. The cells were intermediate in size, and they displayed hairy projections as well. The trephine showed that it was CD20 positive. And on flow, it was a B cell markers were evident, and they also expressed the hairy markers, namely 103, 23, 123, 11C, and LAIR. Subsequently, his BRAF mutation was also positive. My third case is 70-year-old Mr. DK. He was RVD negative, and he had an unremarkable medical and surgical history. And he presented to his base with slowly enlarging lymph nodes with no constitutional symptoms. And on examination, he had generalized significant lymphadenopathy and nil else. His full blood count, if you just looked at it, showed a lymphocytosis and mild anemia. Right. And sorry, this, I can't, oops. All right. And on his peripheral smear, they also showed some lymphocytes with cytoplasmic projections. However, I mean, if you just had to look at this full blood count, you'd probably think this is a CLL, which we commonly see. And that is initially what my thought was until I saw the peripheral smear. The CT scan confirmed that there was extensive lymphadenopathy in the neck, axilla, chest, and abdomen, and there was no splenomegaly. A bone marrow was done, and this was an easily obtained aspirate. A large population of mononuclear cells, about 91%. And they also had cytoplasmic projections. On his flow, B markers were identified, and I'm sorry, this is a very complicated flow, but there is the hairy cell markers that are identified were 11C and 123. And the diagnosis or the suggestion was that this was a hairy cell variant, and his BRAF was negative. So at this point, I would like to tell you why I call this a hairy situation. So medical registrars and medical officers rotate through the hematology unit. We are a 3-man band. It's myself, a medical officer or a registrar, and an intern on good days. And I am by no means a superstitious person, but there is one particular medical registrar who, when he rotates to that discipline is always extremely busy, and yeah, that registrar will give the consultant a run for their money. And at this stage, when I had this registrar, these 3 patients were in my ward at the same time. I kid you not. This was exactly 2 years ago, in April or May of 2019. So it was indeed a hairy situation for me at the time. And at this stage, I'm going to hand over to Rita to talk about the pathobiology.
Okay, Rita.
Good afternoon, everyone, and thank you for the kind introduction, Charlene. That was quite an interesting array of cases presented by Maurice, and we had 2 confirmations of classical hairy cell leukemia, and then the third possibly being a variant hairy cell leukemia. So, you know, hairy cell leukemia it's a rare entity accounting for less than 2% of mature B cell malignancies. But, you know, if you see one of these cells,
Rita, can you
yes,
go to the top of and click on slideshow so that you
Slideshow,
project,
sorry.
yeah, and then yeah, from current slide, and then we probably will, yeah.
No, I don't seem to be getting slideshow. I'm not sure why. Okay,
Try
here
at the
we go.
bottom. Oh, got it. Okay,
Here we
thanks.
go. Right. So as I was saying that, you know, classical hairy cell leukemia, it's a rare entity and it accounts for less than 2% of mature B cell malignancies. But if you encounter one of these cells in the peripheral blood, it's guaranteed to give you 100% excitement. And, you know, you look at the classical features of the neoplastic cell. It's about 1 to 2 times the size of a normal lymphocyte. It has a central or eccentric nucleus, and the nuclear outline might vary from round to oval to indented, even bean-shaped, folded, or angulated has been described. The chromatin is, they have a ground glass appearance, and the nucleoli are generally inconspicuous. The cell has moderate amounts of basophilic cytoplasm, which is agranular, but on occasion one may see fine eosinophilic granules. It might even have a mottled appearance due to the presence of numerous fine vacuoles. And the cytoplasmic outline has been described as hairy, lacy, or serrated. So the scope of this talk, I'm going to be covering the pathobiology of classic hairy cell leukemia, clinical and histological features related to many of the unique aspects or personality of the cell, and then rounding up with differential diagnosis. So I'm going to undertake a short review of B-cell ontogeny because I want to place the hairy cell in context of its postulated normal counterpart. And to do so, I think one's got to appreciate how important the B-cell receptor is in maturation and development, and also the immune effector function of the B-cell. So initially, before the light chain rearranges, a precursor B-cell receptor exists, consisting of two heavy chains, surrogate light chains, and accompanied by the coat proteins, immunoglobulin alpha and beta, or your CD79A and B. Post rearrangement of the light chains, you have a functional, mature immunoglobulin molecule with the heavy chains, light chains, and again attended by the coat proteins. So the B cell, the progenitor B cell in the bone marrow, arises from a common lymphoid progenitor cell. At the pre-B cell stage, there is rearrangement of the immunoglobulin heavy chain gene. Right? And let's go on. What I have here is a highly schematic representation of the heavy chain gene locus on chromosome 14q32. And you have the DNA sequences for variable, diversity, joining, and constant regions dispersed along the strand in germline sequence. And two combination events must occur to get a functional gene. So diversity and joining combine first, and then that is followed by attachment of a variable region. Now going a little more in depth into the variable region sequences, there's about 100 gene segments in the variable region, of which 51 are considered functional genes. The rest are pseudogenes or having been found to be productively rearranged. And these 51 genes are further arranged into 7 families, the VH1, 2, 3 to 7. Now, if you look at what happens in hairy cell, classical hairy cell leukemia, it tends, the phenotype with favorable features, favorable clinical features, tends to use the VH3 family, and in particular, VH321, VH330, and VH333. Hairy cell leukemia with aggressive clinical features prefers to use, or it's been found to have the VH434 gene. So the constant mu and delta are transcribed initially together, and then in the cytoplasm of the cell will undergo alternate splicing to form a mature heavy chain, carrying, and a single cell can carry either the mu or the delta. So At the immature at this stage, it will complex with the surrogate light chain to form the precursor B cell receptor. At the immature B cell stage, then rearrangement of the light chains occur so that you have a fully functional mature immunoglobulin molecule, and the cell will express both IgM and IgD when it exits the bone marrow as a naive mature B cell on its way to homing to secondary lymphoid organs. So upon exposure to antigen, a sequence of events occurs. The cell, there's transient generation of plasmablasts, which are capable of secreting antibodies, on its way to maturing into a short-lived extrafollicular plasma cell. Some of these cells will then enter the germinal center. They will expand in numbers to fill the follicular dendritic meshwork and mature into centrocytes. And two critical processes occur in the germinal center. Somatic mutation, which allows for affinity maturation of the immunoglobulin, and class switch recombination. So the centrocyte, having developed from the centroblast, then has immunoglobulins that has the immune benefits of these two processes. So the centrocyte will then exit and may go one of two differentiation pathways, either into a quiescent memory B cell that is capable of rapidly expanding during a secondary immune response, or it may differentiate into a long-lived plasma cell that's responsible for persistent antigen-specific antibodies. Now, if I were to tell you that in the hairy cell, classical hairy cell, it's been found that these cells express multiple clonally related isotypes, and they also show VH gene usage, as I've shown you before. Where in the scheme would you place it, as being derived from? Well, it's not really certain for now, but it's postulated to be a late activated post-germinal center memory B cell, or possibly a splenic marginal zone B cell. And what then is the transforming event in the cell that leads to clonal evolution and production of hairy cell leukemia? If you will recall that all cellular processes in the B cell, whether it's proliferation, differentiation, or immune effector function, it's dependent on the capturing of a signal from the environment by a receptor on the cell membrane, and then transporting that message across into the nucleus. And signal transduction in the B cell uses three main pathways: the phospholipase C gamma 2, the phosphatidyl inositol 3 kinase pathway, and the MAP kinase signaling pathway. Now, my only intention in putting up this slide is to just illustrate how complex this intracellular communication web is and the multiple crosstalk mechanisms that exist, right? So you can heave a sigh of relief that I'm not going to go into each and every molecule in this pathway for now. But around 2003, it emerged that the MAPK pathway seemed to be playing a very important role in survival and growth of the hairy cell malignancy. And under normal circumstances, MAPK, or mitogen activated protein kinase pathway, is quite important for cellular growth and proliferation. So we're going to hone down on the MAPK signaling pathway so that one can better understand what goes wrong in that cell to corrupt it. So when the ligand interacts with the receptor tyrosine kinase, it undergoes conformational change. A connector molecule called growth factor receptor binding protein 2 then attaches to the receptor and interacts with the guanine exchange factor called SOS, or son of 7-less. Now, you have the formation of a complex, receptor, GRB2, and SOS complex. And the effect of that is to bring the SOS receptor in close proximity, the SOS molecule in close proximity to the receptor phosphorylation sites. So the SOS concentration starts to increase near G protein, RAS. It's in its inactive form, RAS GDP. And as the concentration of SOS increases, RAS GDP converts to its active form, RAS GTP. And in this form, RAS GTP will bind and translocate RAF from the cytoplasm, bringing it into close proximity to the cell membrane. So what is RAF? It's a protein kinase with serine threonine kinase activity, and it's activated by binding to a G protein. There are 3 subtypes: the CRAF or RAF1, the ARAF, which has the weakest kinase activity, and then BRAF with the strongest kinase activity and also most prone to mutations. So that is a little diversion and history on the RAF. So RAF, once activated, will activate MEK1, 2. This is mitogen activated extracellular signal regulated kinase. An activated MEK in turn will activate ERK, again by phosphorylation of the tyrosine and threonine regulatory sites. The activated ERK will then translocate to the nucleus and regulate activity of transcription factors there, again through phosphorylation. ERK can also phosphorylate a number of cytoplasmic target proteins and regulating their activity as well. So the end result of the MAPK signaling pathway is proliferation, growth, and survival of the cell. Now, around 2011, a mutation in the BRAF gene was detected using whole exome sequencing in a patient with hairy cell leukemia. And the details of that mutation is that on exon 15, thymine was exchanged for adenine. So with the result, valine is substituted by glutamate in codon 600. So this leads to a constitutive activation of BRAF by autophosphorylation, disrupting proliferation, differentiation, and cell cycle regulation. So it's driving this arm of the pathway. So BRAF mutation has been found in up to 80 to 90% of patients with classical hairy cell leukemia. And indeed, it is considered a disease-defining mutation. A small number of patients with classical hairy cell, especially the cohort that uses the VH434 gene, they've been found to be, they are BRAF negative, and they've been found to have mutations in the MAP2 kinase 1 gene, which codes for MEK1 and 2. So just to summarize, we've got a case building up now for what constitutes favorable characteristics in terms of the molecular aspects for classical hairy cell, and what constitutes factors for aggressive disease. And this slide is just a summary for that. Now, other cooperating alterations also have been found in the cell, hairy cell, which include overexpression of cyclin D1, inactivation of the cell cycle inhibitor P27, TP53 mutation or deletion. It tends to be infrequent, but it's advisable to assess, especially if your patient has resistance to purine nucleosides. Histone methyltransferase mutations, and then also activation of the phosphatidyl inositol 3 kinase pathway, which has an anti-apoptotic effect. So the end result of all of that is the hairy cell leukemia. And characteristically, this cell prefers to prowl in the peripheral circulation and lodge in bone marrow, splenic red pulp, and hepatic sinusoids. And it gives rise to the common presenting features, which is visceromegaly and cytopenias. Constitutional symptoms are common, as well as increased incidence of infections. The rare presentations include spontaneous splenic rupture, bulky adenopathy, lytic bone lesions, osteosclerosis, leukocytoclastic vasculitis, autoimmune hemolytic anemia, infiltration of soft tissue and CNS, and they may present with ascites and pleural effusion as well. So I'm going to look at some of the unique features of the hairy cell and how specific clinical and histological findings that we encounter in the patient are actually related to expression of chemokines, adhesion molecules, and cytokines. And that is what I meant by saying that nothing in life is actually random. So let's start with the hairy outline of the cell. So the cell membrane is quite rich in F-actin. And what's been found is that the F-actin is cross-linked and aggregated into filamentous projections. And this is aided and abetted by overexpression of protein CD9, PP52, and growth arrest-specific factor 7, together with constitutive activation of the Rho GTPases. Now, under normal circumstances, these molecules and the Rho GTPases are responsible for cell shape, for motility, and you've got a disruption of the intensity of expression of these molecules, and that's what's giving you the hairy outline of the cell. So hairy cell, classic hairy cell tends to share the lymph nodes, and that is attributed to overexpression by the cell of chemokine receptor 4 and CD9, and downregulation of L receptor 5 and 7, molecules that are important in lymphocyte homing to the lymph nodes. Hairy cells do show a preference for the splenic red pulp and hepatic sinusoids, and that is due to overexpression of very late antigen 4, which interacts with vascular cell adhesion molecule 1. Splenic pseudosinuses are also a characteristic histological finding, and it refers to accumulation of red cells in vascular lesions that are lined by the hairy cells. And this is on the basis of overexpression of CD51, which is a receptor for vitronectin. And vitronectin is quite, the splenic red pulp is quite rich in vitronectin, and therefore it favors accumulation now of the hairy cell in that domain. CD51 is also important for motility of the hairy cell. So A common finding in the bone marrow is that of fibrosis. And this is due to increased expression of CD44 isoforms, which bind to hyaluronan and stimulates basic fibroblast growth factor mediated production of fibronectin. In addition, the hairy cell also has an increased output of transforming growth factor beta that encourages the marrow fibroblast. So, other features in the bone marrow, you're looking at the pattern of infiltration, it tends to be interstitial, and cellularity is usually normal to increased, and one typically sees, a loose arrangement of lymphoid cells with a fried egg appearance due to the abundance of cytoplasm. This slide illustrates it quite beautifully, the fried egg appearance of hairy cells arranged in the bone marrow. So be aware though that up from 10 to 15% of marrows may be hypocellular, especially in the elderly. And it is a diagnosis that one should keep at the back of the mind, especially if you've got an elderly patient with reduced cellularity and a splenomegaly, and one would need to actively interrogate that marrow for the presence of hairy cells. So there's some, I'm just going to go into some useful stains that one could use or apply to the bone marrow. CD20, and the extent of whether you apply CD19, 22, FMC7, and CD79A will depend on your resources and how confident a diagnosis you have on the flow cytometry. So hairy cells typically show bright CD20 staining. Annexin 1 stain, this is a molecule that plays a role in inflammatory response and phagocytosis. It's one of the most highly upregulated genes in hairy cell leukemia. And typically the cells show strong membrane or cytoplasmic staining. It does not stain normal B cells or other B cell malignancies. But remember that it is positive in myeloid cells, macrophages, and subsets of benign T cells. So it's not really useful for very low degrees of infiltration or for assessing residual disease. And as a general rule, you should always compare the annexin 1 to a B cell antigen stain like CD20. The TBET stain, TBET is the T-box transcription factor, or TBX21. It's normally found in the Th1 helper T cells and some B cells where it's thought to play a role in class switching. It's a nuclear stain, consistently positive in hairy cell leukemia, and can be quite useful for residual disease. Now, hairy cells have acid phosphatase isoenzyme 5 in cytoplasmic granules. And this particular enzyme is resistant to inhibition by tartrate. So this principle has been exploited for the cytochemical stain trap. And typically, hairy cells will show bright red granular cytoplasmic staining. Weak staining is of dubious value, really. And in recent times, because the trap stain tends to be technically quite demanding, an immunohistochemical version has made its way onto the scene, but just be aware that it's not as specific as the cytochemical method. Then yet another stain, the DBA44, which targets an unknown fixation-resistant antigen found in normal mantle zone B cells. It's also expressed in endothelial cells and immunoblasts, and it's preferable to apply this to fresh cut paraffin sections, as the age of the cut section will impact on stability. The VE1 stain targets the mutant BRAF protein, and also very useful. So, so we have an array of stains that are available, to establish and confirm diagnosis. And again, I want to reiterate that one need not apply the entire panel. I think be judicious in selection of your stains, and especially if you have a representative sample that's been subjected to flow cytometry, where you would have quite a comprehensive panel having been applied to that. So one would be quite selective in applying the stains to the trephine. So at the outset, when one encounters a hairy cell on the peripheral smear, other possibilities should be considered. And there are a number of entities that are offered up as differential diagnosis for the hairy cell leukemia, but I have selected 3 of the closest mimics to discuss. And they are hairy cell leukemia variant, splenic diffuse red pulp lymphoma, and the splenic marginal zone lymphoma. I will go through the clinical features of these 3 entities, and then I'm going to round up with the comparison of the marker profiles for all 4 malignancies. So let's start with hairy cell leukemia variant. In the WHO 2016 classification, this is still a provisional entity, and it has just a passing resemblance to classical hairy cell, but is a biologically distinct entity. It's thought to arise from a B cell at late stage of maturation. And like hairy cell, it has a preference for spleen, bone marrow, and peripheral blood. In contrast, though, it presents with a variable lymphocytosis and a normal monocyte count. The anemia and thrombocytopenia may be of varying severity. So these are examples of hairy cell variant in peripheral circulation. So commonly, the chromatin pattern varies. It may vary from condensed to finely dispersed. And there's a prominent central nucleolus that is reminiscent of a pro-lymphocyte. I quite like this description of hairy pro-lymphocytes, though. It's very apt. The cell has variable amounts of moderately basophilic cytoplasm, and again, one can see villous projections. They've also described blastic and convoluted nuclei in hairy cell variant. In the bone marrow, one finds a lack of significant fibrosis. The infiltration may be subtle, so always apply immunohistochemistry if the diagnosis is suspected. And sinusoidal infiltration is a feature. The spleen shows diffuse involvement of the red pulp, and sinusoids that are dilated by neoplastic cells. Red blood cell legs also feature. Then moving on to splenic diffuse red pulp small B-cell lymphoma. This is also a provisional entity in the current 2016 classification, and it's thought to be of mature B-cell origin, commonly presents with a massive splenomegaly and symptomatic cytopenias. B symptoms and lymphadenopathy infrequent. There we have an example of circulating splenic diffuse red pulp lymphoma cells. And it's a small to medium-sized lymphoid cell with clumped chromatin, inconspicuous nucleoli, and you've got villous cytoplasm. So peripheral blood may show a variable lymphocytosis, again, generally low degree. The bone marrow pattern of infiltration is interstitial and or nodular. And similar to hairy cell variant, we see intrasinusoidal involvement. So whilst the finer details of this entity is still being worked out, for now, diagnosis remains rooted in splenic histology. But of course, the challenge is that tissue may not be routinely available. And what the history does show is the diffuse involvement of the red pulp with blood legs, small to medium-sized lymphocytes with a regular nuclear outline, mature chromatin, and occasional small nucleoli. So quite monotonous. They may have plasmacytoid features, but are negative for cytoplasmic immunoglobulin and CD38. So that's just an example of histology of the spleen in splenic diffuse red pulp lymphoma. So the third mimic for classical hairy cell leukemia is the splenic marginal zone lymphoma, which is a well-established entity in the 2016 classification. And the postulated normal counterpart is a marginal zone B cell stage. This entity shows preferential involvement of spleen, splenic hyaline nodes, bone marrow, and peripheral blood. It may also show hepatic involvement, and there is sparing of the peripheral nodes. Autoimmune cytopenias tend to be common, and again, there's a variable lymphocytosis. So with splenic marginal zone lymphoma, one sees medium-sized cell with clumped chromatin, occasional small nucleoli, and what is described typically as polar cytoplasmic villi. The bone marrow will show either a nodular or interstitial infiltrate or a mixture, and again, intrasinusoidal involvement. So that's a low power of the spleen in splenic marginal zone lymphoma, which originates in the white pulp. And one sees a central zone of small round lymphocytes that surround and replace the reactive germinal centers. There's obliteration of normal follicle mantle zone. And then the small mature cells will merge with larger cells. They're having more immature cytoplasm in the marginal zone. And there we have, the CD20 staining, quite strongly positive, and this entity would be negative for CD5, CD10, 43, and BCL2. So, excluding the CLL and the follicular lymphoma. So I've described the clinical features of the three entities in three mimics in relation to classical hairy cell leukemia. And I'm going to round off the discussion with a comparison of the marker studies. So classic immunophenotype of hairy cell shows a bright monotypic surface immunoglobulin. There's bright co-expression of CD20, 22, and 11C. There's expression of CD103, 25, 123, TBX21, annexin A1, FMC7, CD200, cyclin D1, and LAIR. It's usually negative or dim for CD5, 23, 10, and 27. So in table form, if we look at it with classical hairy cell against the three mimics, all of them show bright CD20 expression. Variant, hairy cell variant, will show 11C and 103, and the other two, there's variable expression of 103 and 11C. Estelle McTutes from Royal Marsden Hospital, she derived an immunological scoring system based on 11C, 103, 123, and 25, giving you a total of 4. So you would score 1 for each of the marker being present. And classical hairy cell typically will give you a score of 3 to 4 with these 4 markers. The other 3 entities will give you a score of 0 to 2 at the most. So that is quite a useful tool to use in distinguishing classical hairy cell from its mimics. So annexin A1, very specific for hairy cell leukemia, and also SOX11 outside of mantle cell lymphoma. It's very useful for the diagnosis of classical hairy cell. As you can see, none of the other entities express that marker. All 4 are positive for DBA44, and the mimics are positive for CD27, whereas hairy cell leukemia is not. So that concludes my presentation on pathobiology of classical hairy cell leukemia. And I hope that I have given you an understanding of where the cell comes from and how it goes, and how to distinguish it from its mimics. Thank you. I'm going to return the presentation back to Maurice, and she will complete with therapeutics.
Thank you, Rita, for a really, really good. I've learned so much myself, actually. Thank you so much.
Pleasure.
Okay, I'm going to continue. And just to confirm, you can hear me?
Yes.
I think clear.
Yes, we can.
Thank you. All right. Now, I know Rita has ended with the immunological score, and I just needed to recap that 1 point is given for 11C, 103, 123, and 25. All right, and a score of 3 to 4 is observed in 98% of cases. And in other hairy cell disorders, the score is usually 0 or 1 or 2, actually, that Rita mentioned. So just to review those 3 cases, the case 1 was a 46-year-old female with a 46-year-old female. The aspirate I could not obtain. She did have monocytopenia. Her immunological score was 4. She had a splenomegaly and a BRAF was positive. The second case was the 79-year-old. His cytopenias were not so severe. Aspirate was easily obtained. He did have monocytopenia. His immunological score was also 4, and splenomegaly, although it was a lot smaller, at 2 centimeters below the costal margin, and his BRAF was positive. The third case was a typical hairy cell variant. Aspirate was easily obtained, did not have monocytopenia, and the score was 2. No splenomegaly, just lymphadenopathy, and BRAF was negative. So hairy cell leukemia treatment in the last 40 years has come quite a long way. From the 1980s, when they were using interferon, then the purine nucleoside analogs in the 1990s, monoclonal antibodies like rituximab in the 2000s, and now we've even got BRAF inhibitors. So these are some of our treatment options. All right, bendamustine is also one of them. I will talk about BRAF inhibitors and the other pathway, the BRAF-MEK pathway inhibitors. I'll briefly discuss protein tyrosine kinase inhibitors, and I will end off with immunotoxins. And you may be wondering, what about splenectomy? Well, splenectomy doesn't really have much of a role in hairy cell leukemia because the purine nucleoside analogs are quite effective in reducing the size of the spleen. Right. So before we discuss treatment, let's talk about risk stratification in hairy cell leukemia. So Rita has mentioned a lot of the molecular reasons for poor prognosis and resistance, and I'll deal with some of those, but also just the clinical aspects. So splenomegaly, more than 3 centimeters, a leukocytosis, hairy cells in the blood, a high beta-2 microglobulin, lymphadenopathy, and then the IgHV mutational status has also got prognostic implications, where the unmutated IgHV have a shorter overall duration than those with the mutated IgHV. And as she has mentioned, the VH434 positive status also implies a poorer prognosis. These patients have a higher disease burden at diagnosis. They have a poor response to standard therapy. They have shorter overall survival, and they have an absence of the BRAF mutation. Also, short telomere length would also indicate poor prognosis. So, what are the treatment indications? Well, if a patient is symptomatic, or if there is declining heme parameters of at least one of the following. So a hemoglobin of less than 11, a platelet count of less than 100, and an absolute neutrophil count of less than 1. And symptomatic splenomegaly may serve as an indication for treatment. My first patient, the 46-year-old, she had lots of heme parameters. I mean, her absolute neutrophil count was 0.08. The second patient had an HB of 12.8, platelet count of less than 100, and his absolute neutrophil count was less than 1 at 0.9 or so. So let's talk about the purine nucleoside analogs. So they are the mainstay for hairy cell leukemia for physically fit and symptomatic hairy cell leukemia patients, conferring in most cases a long overall survival in the first line. There are no randomized trials comparing both drugs, and there's no evidence to date in the literature proving the superiority of one drug over the other. They have a similar complete and partial response. But in a large US database of around about 750 patients, cladribine was chosen 75% of the time, and it is a drug that we have in the state sector, which we use. All right, so cladribine has got several different schedules and routes of administration. It can be intravenous or subcut. There are some 5-day schedules or 7-day schedules. Pentostatin is given as a short intravenous infusion every 2 to 3 weeks until remission is achieved. Now, these drugs can cause temporary myelosuppression and prolonged immunosuppression. And it is advised that granulocyte colony stimulating factor, or Neupogen, which we have here, and prophylactic anti-infective agents like cotrimoxazole and acyclovir may be initiated during treatment and continued for up to 6 months until there is adequate neutrophil and lymphocyte recovery. And in the case of cladribine, these drugs should only be administered after therapy with cladribine, because rashes can occur when the drugs are given concurrently. And blood transfusion post-therapy should be with irradiated products indefinitely. Now, let me quickly talk about the role of rituximab. Monotherapy is not really advocated unless the patients cannot tolerate the purine nucleoside analog, or the patients present with infection. Chemotherapy with cladribine followed by rituximab has been introduced or for early hairy cell leukemia in order to achieve negative MRD and get a durable complete response. There has been a phase 2 trial of 59 patients where rituximab was added after cladribine. The regimen was well tolerated with no severe or unexpected toxicity. And preliminary data suggests that adding concurrent rituximab to cladribine could improve a durable complete response. It is also used as second line with the purine nucleoside analog. And I will mention this a bit later, there is a new trial out that indicates that it may even be combined with the BRAF inhibitor, vemurafenib. All right, so let's look at the treatment algorithm. So if the patient is asymptomatic, watchful waiting is an option if the cytopenias are minimal, all right? And one of the most challenging clinical situations involves a patient with symptomatic hairy cell leukemia with a febrile infection. And it's been suggested to control the infection prior to instituting the purine nucleoside analog. And if it is not possible to control the infection, use interferon transiently and then use a purine nucleoside analog. And interferon can also be used as an alternative in pregnant women. If your patient is symptomatic, obviously monotherapy with a purine nucleoside analog, namely cladribine or pentostatin, can be used, or chemoimmunotherapy. As I've just mentioned, cladribine plus rituximab is an option. Now, let's talk. So in the long term, about half of patients will relapse in the first 5 years of treatment. And patients relapsing after previous treatment with a purine nucleoside analog are more difficult to treat, and they are at a higher risk to have significant and impaired reduced overall survival. In addition, they become progressively less sensitive to the purine analog. And this may cause, and the nucleoside analogs will also cause cumulative hematological and immunological side effects. So the therapeutic options depend on the duration of the first remission. If the remission is after 5 years, you can consider a purine analog as salvage therapy, namely cladribine or pentostatin. If it's between 2 to 5 years, you can consider chemoimmunotherapy, cladribine plus rituximab or pentostatin plus rituximab. A study of 14 patients showed that cladribine, which was followed by rituximab, showed a complete response of 100%. And in a second study of 26 patients with cladribine and pentostatin, where 20 patients had concurrent rituximab and 6 patients had sequential rituximab. And that it showed an overall response rate of 96% and a complete response rate of 88%. And if relapse occurs before 2 years, the hairy cell diagnosis has to be confirmed and risk factors have to be evaluated. And then patients should be considered as relapsed or refractory, and I will discuss treatment options there. But I would like to point out that bendamustine can also be considered with rituximab. And there was a small study, admittedly, of 12 patients where bendamustine was combined with rituximab, and that showed a 100% overall response rate with a 100% complete response. Now, I'm using words like complete response and partial response, but I actually haven't mentioned how to actually do it. So, response assessment. One needs to do a physical examination and look at the spleen size. Look at the full blood count and obviously your heme parameters and the presence or absence of hairy cells, etc. And a bone marrow should be done to assess if normal hemopoiesis has been established with eradication of the leukemia. So there should be normalization of peripheral blood counts. And there should be a hemoglobin of more than 11 without transfusions, platelets of more than 100, and an absolute neutrophil count of 1.5. There should be regression of the splenomegaly by physical examination, disappearance of the hairy cells from the bone marrow. Now, the bone marrow should only be done 4 to 6 months after cladribine therapy. And it should be performed after a clinical response to pentostatin treatment. And flow is a useful as a useful tool to assess MRD. And the reason you delay the bone marrow after cladribine is because bone marrow recovery may take months after treatment with a purine analog. Now let's talk about MRD. Current consensus guidelines regarding hairy cell leukemia do not make specific recommendations regarding where or how to quantify MRD. Is it in the bone marrow or the peripheral blood? Is it with the use of flow cytometry or immunohistochemistry or molecular assays? And the question is, do you treat some of these patients who have got minimal residual disease? So this is maybe a question we can leave for later. In a partial response, there are no cytopenias, no hairy cells, and there is a 50% improvement in organomegaly and bone marrow infiltration. All right, I've mentioned the response assessment on the bone marrow. CD20 staining can be done in conjunction with a morphological assessment and with the use of DBA44 to identify subtle residual infiltration. In a complete response, immunohistochemistry should reveal no clustering of cells defined as more than 3 cells of CD20 positive and DBA44 positive cells. Right, so if a patient is identified as relapsed or refractory and it's less than 2 years after they've had a response to a purine analog, you can consider BRAF inhibitors. You can consider an immunotoxin. And then there are other MEK inhibitors. And then the alternative options like vemurafenib plus rituximab, which I will discuss, and the BTK inhibitors. So let's briefly discuss BRAF inhibitors. Vemurafenib, and this is being tested in 2 separate multi-center phase 2 trials in the US and Italy. And they showed an overall response rate of 196% in their respective centers. However, a complete response was only observed in 42 and 35% respectively. The inhibitors were well tolerated, and they had mostly grade 1 to 2 adverse drug reactions. Side effects included rash, photosensitivity, warts, arthralgias, arthritis, and skin tumors accounted for about 9% of the adverse drug reactions. I won't go into too much detail, but this is a study which has been published now in May 2021 in the New England Journal of Medicine. And this showed that vemurafenib plus rituximab could be used in refractory or relapsed hairy cell leukemia. And just to I just took a few take-home points from this study. Firstly, it was a small study with 30 participants. It was a single phase 2 trial in Italy. Now, remember, I had mentioned that vemurafenib had been used in 2 multi-center trials in Italy and the US, and this was a follow-on from that. And in these patients had been heavily pretreated, but 87% had a complete response versus 35% in this in the Italian group with vemurafenib monotherapy. And 65% of those patients even had no minimal residual disease versus 0 in the monotherapy group. And they also halved the time to complete response and the exposure time to side effects. Immunotoxins. And as the hairy cell leukemia cells express CD25 and CD22 at a high density, clinical trials with anti-CD22 immunotoxins are ongoing. The immunotoxins are a fusion of a bacterial toxin to the variable region of a monoclonal antibody that is directed against a specific cell surface target, such as CD22 in hairy cell leukemia. And this represents a new therapeutic option. And so this brings me to a moxetumomab pasudotox. And preliminary results obtained are promising in the phase 1 clinical trial, with an overall response rate of 91%, including 59% of a complete response with no dose-limiting toxicity. The maximum tolerated dose has not been established. However, side effects include capillary leak syndrome and thrombotic microangiopathy. Bruton tyrase kinase inhibitors like ibrutinib inhibits survival and proliferation of hairy cells in vitro. In a phase 2 trial of 17 cases of relapsed refractory hairy cell leukemia, the overall response rate was 60%, with a 25% complete response and a 35% partial response. So this does show promising, and it warrants further investigation. And I'll briefly discuss hairy cell leukemia variant because this was the diagnosis in my other patient. There's no established consensus. First-line therapy relies on the association of cladribine with rituximab combined or with a sequential scheme. And the same scheme could be followed in cases of relapse. And ibrutinib could represent an alternative therapy either as first-line or relapse. And there is a place for watchful waiting in some asymptomatic patients. Okay, so before I end, I would like to just update you on all my patients. So the first case, the 46-year-old woman with the severe cytopenias, was referred to King Edward, and she received cladribine, a 5-day IV scheme, and she understandably became quite septic. She was then referred back to Grace Hospital for management, and she was with us for a few weeks, and we tried all sorts of antimicrobials, but unfortunately she demised. The second patient, the 79-year-old, the family did their own research on hairy cell leukemia, decided the side effects are worse than the actual disease, and decided that they were not going to opt for therapy. And that patient was 79 years old. And incidentally, 2 weeks ago, the daughter phoned me. Well, dad is actually still alive at 81. And her question to me was, is forgetfulness a sign of hairy cell leukemia? And I said, no, it's a sign of getting old. So, but dad is well, and I've trying to convince her to go to a GP to do his full blood count with his differential count, although I'm not too sure if it'll make a difference because they are still adamant that no treatment is necessary. The third patient with the hairy cell variant was referred to King Edward, and unfortunately I have been unable to trace his file, and it's made difficult because he has a surname which is unusual in KZN, and it's got many different spellings, and we have just been unsuccessful in finding his chart. And these are my references, and that concludes my talk.
Thank you, Maurice. That was really a very, very good overview, Rita, as well. Thank you so much. I have a question, Rita, please. You mentioned the DBA44 and the VH434. Are we testing for that in our patients? I mean, I know this is rare and we don't get that many cases, but in an empath at least, they are doing it.
So Charlene, you speak of the DBA44.
Yeah.
That's an immunohistochemical stain, and that is available.
Okay.
The VH434, yes, that is a test that is available. And I was speaking to Dr. Robin Marshall from Oncolab, and they do the LymphoTrack. So the LymphoTrack will give you the IgH mutational status, and will also give you information on the VH gene usage. So you could use that to, as an additional criteria to stratify, risk stratify your patient. So yes, both those modalities are available.
And Rita, how often are you picking these up in private? The reason I ask, because in my experience over the years, we've had very few patients, and all of these patients have been older Caucasian patients. I have not seen any patients of any other race group in our clinic. And so I just want to know, what are you seeing in private? And
It's a rare entity, and I think we probably go at a rate of maybe one a year. And I know that JP Jamendra, he's got an Indian patient at the moment,
okay.
a man in his 50s, in his early 50s, with classical hairy cell leukemia. So, yeah, that's our experience in private. But I was quite interested the comment that Maurice made regarding the morphology report that was rendered by one of the technologists and querying a hairy cell leukemia. And I think it just brought home to me that how often we don't read the morphology reports, and we should be making an effort to trace whatever results we can find on a patient, because one never knows what pieces of the puzzle you can pick up and put together.
Okay, let's see. So Jacques has a question. Has anyone made the diagnosis in African patients? We had one confirmed BRAF mutated hairy cell in an African patient. If I remember correctly, Dr. Jafta published it. So that's what Jacques from Bloom says. And then he also says, in general, my experience with cladribine in classical hairy cell leukemia has been very good. Yeah, so the one or two patients that I remember in our clinic responded well to cladribine. So we've obviously not had experience with pentostatin or any of the other agents. But, I think the important, getting back to exams and that, so for the people going for their clinical exams, it's an important differential in a patient that has pancytopenia with a splenomegaly. I think that's an important differential to be on your list. And obviously, we've mentioned the variant, which might present with a higher white cell count. So those are important things actually just to bear in mind. And I don't know if anybody else wants to comment or has any other experience. Vernon, Jacques, if any of you want to say anything from your centers, because as I said, my experience obviously is limited. And I must say I learned a lot from Rita's, her description of the pathophysiology and the new lab tests. And because I haven't been up to date with that. So I must say there's a lot I have learned, and I'm sure that the registrars and fellows as well may have benefited from what you've presented today, Rita. And then as for Marie's, you've given us 3 really, really good cases, and so to keep an open mind, I think, is very important when faced with patients with splenomegaly, cytopenias, and although this is a rare condition, important to look at the smear. And so Marie's just has put up she says yes. So the 46-year-old patient was black and the 79 was an Indian. Okay, and then Moses says he's seen 2 black African male patients. I actually think maybe perhaps all of us should get together and put our cases together and and actually do a write-up, because it seems that it is a bit different from what we are seeing in the literature, and maybe it'd be good to show our South African experience.
Charlene, can I make a comment?
Yes. Hi, Estelle. How are you?
Hello. We are actually doing it at this moment with a young intern who is very happening, and So we have the same theory that all of us have. And we have had our first Black patient recently diagnosed. But apart from that, it looks like to be mostly mixed race or Caucasian. I just, one thing, I can't remember if it was Maurice or Rita, I think it was Maurice who said, what, you are 100%, what did you say? 100% happy when you make the diagnosis? 100% satisfaction? All I can say is it really is 150% satisfaction making this diagnosis. I thank you for saying, you must actually say what you said again, because I want to remember that. What did you say? 100% what?
It was me, Estelle. So,
Yeah.
you know, I said to you, I said initially that, you know, it's a rare entity accounting for less than 2%
Yeah.
of lymphoid malignancies, but it's guaranteed to give you 100% excitement when you spot
Yes.
what cells on the peripheral smear.
Beautifully said, because it's 100% excitement for everybody looking through the microscope. I just 100% agree with that. It's such a beautiful, beautiful diagnosis, beautiful little cells. And there's this added wonder that in contrast to these beautiful leukemias we see and these beautiful lymphomas we sometimes see with these awful, awful outcomes, some of them, these patients all do very well. And that's why it's 100% excitement. So just want to say thanks for the beautiful overview of treatment. We really learned a lot, all of us. I just think that the beautiful thing about these patients is that it still holds true that there's about a 10 to 15 median response to cladribine, 10 to 15 years. And then if you retreat, and that was shown very beautifully in your algorithms, if you retreat, which is obviously more than that 5-year you gave, 5-year, then there is again a 10-year response, median response. So these patients actually do very well. And the funny thing, which nobody actually, perhaps I missed it when you said it, but it's the young patients, the 40-year-olds, that do poorly sometimes. They are the ones who are resistant. They are the ones who relapse. And I think it's the 46-year-old that died from sepsis. Am I wrong or right?
Yes, that was right. The young died from sepsis.
And I've also had a patient like that long ago, and it is the most devastating thing because it happens and you're like, why the heck did this happen? Because this patient should have had a beautiful outcome. So typically that's the one devastating thing happening during their treatment. I also lost one 40-year-old that was absolutely awful during the H1N1 epidemic. He got it in the ward, and it's just awful. And then I heard from my colleagues in Belgium that they also had a patient with hairy cell with H1N1 dying during their therapy. So there seems to be some interesting link with a viral infection. I don't know, but yeah.
So, Estelle, are you covering your patients with antivirals and Bactrim or Dapsone in the post, chemo period, and like how we would for patients on fludarabine, for instance?
Okay.
Are you doing that?
Yeah, we do, although you may have seen the literature on younger patients may not need the Bactrim prophylaxis after being given purine analogs. It's kind of a decision. I'd love to hear what Vernon says. I can see he's got something to add. So yes, you're supposed to give Bactrim, but there is a room for thinking if it really is necessary in younger patients. I'm just mentioning that, but to be correct, you should give it. The antivirals, I'm going to be very honest with you, Charlene. It's so long since I've treated one, I haven't thought deeply about it. Let's hear from Vernon. I don't know if he's got something to say.
Yeah, I mean, I don't know what the correct answer is, but I do believe in treating all patients who receive purine analogs with at least herpes zoster prophylaxis or herpes prophylaxis.
Yes.
And I do give them Bactrim as well. So for me, that is a routine. I have seen, well, I must admit, I mean, the PJP patients I've seen has been mostly with fludarabine, and this is a short course but still, mechanistically, I don't see why it should be that different. One thing I do want to mention, just for interest's sake, and this may be anecdotal again, but I've had an interesting observation with one of my patients who I still treated in Bloemfontein, and she then very successfully, she then relapsed, was treated again, but lived very far away. And I moved to Cape Town, and there was sort of a disconnect in the follow-up. But long story short, when we connected again, it appeared that she was for about 4 or 5 years. If I look back at all the different blood results she had actually had numerous full blood counts. The full blood count was consistently below 0.5, like 0.3, 0.4. She never, in all those years, had a single infection, which I thought was quite remarkable. And she was not on Bactrim any, for the long term. That was just in the first 18 months or 2 years or so post-treatment. So it was quite interesting. And I've always wondered, even though they might be more susceptible to certain infections, whether there's something else going on, because I can't understand how someone walking around in the community could remain, sepsis free for 4 years with a deep neutropenia and a hairy cell leukemia and previous purine analog exposure.
It's not a severe neutropenia, remember?
It is. It's not a very
0.2
severe.
is a severe one.
No, that's
No.
very severe.
No, I think it really is the 0.2 where people really spontaneously below 0.2 where they, as in, so, and I think that's the other thing you're mentioning. What's very important is that these patients are often not in a complete remission, but as long as they are doing well and have good counts, you can leave them in peace. 20 years ago, there was a deep need, there was a thrust sort of to treat these patients to get them in complete remission. And that has sort of fallen away. And I think one should kind of resist, but I'd love to hear what somebody else says. I see it's 17:32. Perhaps we should stop talking, but do you keep treating patients even if they have good counts? I would say you only treat them if they don't have good responses, retreat them, because it's also, if you go back to the algorithm that was given, you watch and wait if patients are not symptomatic. So I think in the same sense, if they have been treated, you can also watch and wait until it becomes a problem.
Sorry.
Yeah, and I think to add to that, if I may, I think many experts would say that you won't just treat because a neutrophil count is less than 1. It's if it's less than 1 with recurrent infections. So the neutrophil count is not an absolute indication for therapy.
I see one, Simba has commented here, we have a young patient who has relapsed twice and now getting R-Bender with mid-cycle rituximab. And Jacques says he gives his patients acyclovir and Bactrim. And Maurice talks about here, what about irradiated blood products? So theoretically, these patients should get irradiated blood products, but once they are, I guess, if they respond to therapy, then the need for transfusion obviously will be less, or patient wouldn't need it. But in the event of a relapse, I would assume then we would have to use irradiated blood products. So if there's any more questions, so I think we'll close here. So I'd like to thank Maurice and Rita once again for doing such a wonderful job, and I think we've all learned a lot, and we'll see you everyone next week. I'm not certain what the talks are next week, but thank you everybody for joining us today, and have a good evening.
Thank
Shalene,
you.
thank you so much for chairing. I can just say that next week is primary immunodeficiencies and inherited bone marrow failure syndromes, the importance for the hematologist, and it will be presented by the pediatricians from Red Cross. but many of these conditions will be relevant to adult hematologists as well, something that I'm sure I'm going to learn a lot about. So again, thank you to the great speakers and our wonderful chair. Have a lovely evening, everybody.
Thank you.
Thank
Bye.
thank you. Bye.
Wonderful. Very well done. Thank you.
Thank you. Bye.